Good evening, everyone. I have 6 o'clock. Welcome to Emergency Medical Services section of the American Academy of Emergency Medicine webinar, EMTALA and the EMS physician. Let me unshare my screen. Hello, Catherine. So good evening, everyone. Tonight's program will be recorded and uploaded to the website in about 48 hours. If you're in the audience, please feel free, say hi, where you're from in the chat. If you have questions, feel free to raise a hand or put it in the chat, and I will then ask the presenter where it fits in the best. They're meant to be interactive, so please be as interactive as possible. Otherwise, I'm just the one asking the questions. But please mute yourself when you join, and then feel free to unmute if you have a statement, question, or anything along those lines. I would like to introduce Dr. Hashim Zaidi. He is an assistant professor of emergency medicine at University of Texas Health Houston. He's board certified in emergency medicine and EMS and is an advocate for improved pre-hospital education, research, and physician involvement. He serves as the medical director for Harris Health EMS and Harris Health Transfer Center. So good afternoon or good evening, Dr. Zaidi.
Thank you.
So, we're all here in this EMS group because that's what we do, that's what we love. But there's always that monkey wrench of law, trying to, make sure everyone does the right thing all the time. So can you kind of set the stage for us how EMS and EMTALA interact?
Well, first of all, thank you for that warm welcome. It's an honor to be here as part of the AAEM EMS section and talking about the future of EMS. And I'm a firm believer that for a lot of things in life, I think we have to look backwards a little bit to see what the future is going to be, right? And what challenges we may face. I think that's a great question. I think there's a couple ways that we're going to have to answer that. What I don't want to do this afternoon, and I recognize the irony because I've got a PowerPoint slide pulled up here. I don't want to give you guys death by PowerPoint, especially as we're well into happy hour here. But I do want to at least give you guys just one baseline slide, a primer on EMTALA and what the core provisions are. And then we can get into how does that relate to the EMS service, EMS physician, EMS leadership, right? Where does that intersect and how can I be a little bit more aware of what's going on there? So just as a prelude, I have no disclosures. I'm not an attorney. I'm not a legal EMTALA expert. What I am is a medical director for a transfer center and medical director for an EMS interfacility agency for our county health system, a hospital-based EMS system. And as part of that, a lot of what I do, especially on the transfer side, often relates to EMTALA and EMTALA components. And I think EMTALA is often quoted, and many of us who work in healthcare may hear it many times from people working in the EC, people in inpatient, people all over saying, well, how does this relate to EMTALA? What is that, right? But that's what I'm here to clarify a little bit of. But again, I'm not a true legal expert. Please consult your compliance people, your attorneys, your group's risk and compliance organizations, right? Because they may have their own specific risk tolerance as well. What I'm here to do is just educate you guys and give you some of the background. So here it is, my one slide crash course. And I promise I'll stop doing the PowerPoint death after this one slide, right? And this is the one slide on EMTALA that you just need as the background before we get into more interesting topics. What is EMTALA? EMTALA says, these are just some of the main provisions, right? If you come to an emergency department, you have to get a medical screening exam to determine if you have an emergent medical condition, right? And many of you know that if you work as physicians in triage, or even you're involved with the component of intake of patients at emergency centers, right? That is a core component of an emergency department, great. And in that they say, look, you can't delay your exam, you can't delay your treatment, you can't make it at all contingent on how that patient's going to pay or what their insurance is. You can't even ask about payment or insurance until you've started those components of care and at least are stabilizing that emergent medical condition or screening for it, right? We do that every day in the waiting rooms across America today. If you do find an emergent medical condition, well, first you got to treat that medical condition until it's either resolved or stabilized, that emergent condition. That is the contingency. If you find an emergent medical condition, right? I find this patient's having a heart attack, right? You must resolve that emergent condition or stabilize it to the best of your ability first. before you do anything else, right? And if you can't solve that emergent medical condition or stabilize it, right, then you have to arrange an appropriate transfer to another hospital that can do those things, right? And if you are that receiving hospital, you have to take that patient if you have the capacity and capability to accept it, right? So if that hospital A doesn't have a cath lab, they get a STEMI, they call hospital B and they have the capacity to take them and the capability, they've got a cath lab, it's open, ready, waiting, beds in the CCU, right? They have to accept that patient, right? And it can't be contingent on payment, insurance coverage, et cetera, all those things, right? We have to treat that patient. Why are half the things in quotes here? Every single word or phrase, as it is written here, is entirely debatable. That's where the really fun part is, right? When you talk about come to the emergency department, emergency medical condition, right? We have to, these are not defined. These are not defined in the statute. They're not defined in legislation, right? What they are is they're interpreted. They're interpreted by lawyers in cases with real patients that have come forward, right? Where we've tried to say, what are these things? What does this mean? Come to the emergency department. What does this mean, emergent medical condition, right? There's no part of the law that says this is what an emergent medical condition is, right? So that's the fun part. I think the real takeaway I want you guys to take from this, right, is that EMTALA means no dumping. The whole core premise here is I have to treat those emergent medical conditions. I can't dump that problem on to another hospital, another entity, a county hospital, et cetera, right? Especially when it's contingent on a patient's payment or payment method, right? And we'll talk about why that is in a second, but I just wanted to give you guys the patented one slide refresher first.
So that's so that kind of leads to the next question is, so why or how did EMTALA come to be? Why was there a need for this? So what were people doing that there was a need to have EMTALA?
Yeah, and so we're gonna have to run around the clock a little bit, and this is where the history comes in. This is the part that I think is really fascinating, right? If we look back, the case that started kind of the big part of this, right? The case that kind of brought this all to light was a case of a gentleman named Eugene. He went by Eugene Red Barnes, right? He came out of what was essentially thought to be a drug den, or some people in the news stories have described as a crack house, right? He stumbled out of there, fell to the ground. Someone called EMS. EMS brought them to a local hospital. It was a little hospital called Brookside Hospital. It was a tiny hospital, right? And there they did an examination. They did CT scans. They said, look, you need a neurosurgeon. You've got bleeding in the brain that is life-threatening. You need to get to a neurosurgeon right away. So they called local hospitals that had neurosurgeons. They called Contra Costa County Hospital and then Alameda County Highland Hospital, right? Pretty well-known hospital, especially Alameda County, right? And the one neurosurgeon at one hospital said, look, I'm too tired. I can't take this case, right? The other neurosurgeon said, I'll take the patient, but only if the ER physician puts a burr hole in them first and then sends them over, right? Imagine that happening today, that you try to transfer a patient to a higher level of care to a neurosurgeon, and they say, sure, I'll take them, but only if you put a burr hole in them first. Well, the ER physician didn't feel comfortable with that, right? As many of us would not be, right? It's not a routine procedure that we do anyway. Maybe some of our rural colleagues, but the third hospital, SF General, did take them, but they only took it under the condition that the ER physician joined the patient in the ambulance. They said, okay, I'll take it, but you have to come with the patient to ensure that they're stable. And the physician did it. And Mr. Barnes went to SF General, but unfortunately he died a few days later. After that, Dan Rather picked it up on CBS Nightly News, and it was big news. It was big news across the nation. And the question became, especially for Congress, was, is this happening in other places? House of Representatives at the time said, okay, we'll make a subcommittee, we'll investigate this, right? And you think, okay, they investigate this, right? How do they find this out? Do they gather data? Do they do a large study? No, they just solicit anecdotes, right? This was 1985, around that time. They solicit anecdotes, and this is where a famous anecdote exists, and this is where the power of one person can make a difference, right? Art Kellerman was a physician from Memphis Regional. He was working at the county hospital there. And he went in front of that subcommittee, and this is the famous story, if you guys have heard of this. He took out a box of wristbands, patient actual wristbands, and he dumped them out onto the desk, dumped them out on the floor. There's hundreds of wristbands, right? And he said, look, these are all the patients that were dumped onto my county hospital in the last year, right? A very dramatic representation, right? So Congress took these anecdotes, they took these stories, they took Art Kellerman's testimony, and they looked at other cases. They found a woman who showed up to a private hospital. She was having fetal distress. She was pregnant in third trimester, having fetal distress, but the hospital's computer wasn't updated. They said, well, we don't show your insurance on record, right? So we're going to turn you away now, right? We had another case. There was a gentleman in a car accident. He was thought to be bleeding, and they said, "Sure, we'll take care of you. Give us $1,000 down payment, and we'll take you to surgery right now. We'll stop your bleeding. No problem." All right. Otherwise, you can go to the county hospital down the street. You don't have to be here at this hospital, right? Another patient, 2 gunshot wounds, showed up, and then they transferred him to a county hospital because as soon as he was immediately stabilized, right, barely stable, they transferred him to a county hospital, right, because they found out he didn't have insurance, right? So you can see some of these cases coming together. So now, I mean, you guys probably, hopefully, agree that that's probably very unusual, especially in today's day and age, right? So, and I'll just read you some quotes here. And please chime in if you guys have cases, questions. You know, this is meant to be interactive, a little more discussion back and forth. But here's one of the quotes of one of the senators at the time when they were kind of reviewing this. He said, "The practice of rejecting indigent patients in life-threatening situations for economic reasons alone is unconscionable. All Americans, rich or poor, deserve access to quality health care." This was a Republican senator from Minnesota at the time. Right? And here's the counterpoint. Here's a senator from Utah, Republican senator from Utah, who said, "I do not support the provisions of EMTALA, including this bill. I believe they are premature, over-regulatory, and unnecessarily punitive." That was Senator Hatch, from a Republican from Utah at the time, right? And this is one of the shortest turnaround times. Less than 2 months from when the bill came to the House, it proceeded to final amendments and public input and comment. And I'll have you guys maybe take a guess at this. I hope you guys will chime in. There was only two recorded public comments on EMTALA, right? There was a very short turnaround, right? And there's only two public comments. One was a law firm from Miami, and the other was a letter from ASEP president at the time, Bruce Janiak. What do you think they both said? Do you think they said, "Hey, this is a great idea. EMTALA should absolutely be there to help our patients, prevent this patient dumping, right? To transfer patients without stabilizing them. That's unconscionable." Do you think they said that, or what do you think they said?
I'm gonna guess that the way you're wording it is that they were both probably against it for some reason, which I don't know.
Yeah,
Um,
yeah. I mean, this is the most interesting part when I was looking at this. It was a letter from ASEP, and it said that this is interceding into the patient-physician relationship in an over-regulatory way that you cannot get between a patient and a physician. If that's what the doctor decides, that's what the doctor decides. They both thought that this was over-regulatory, right? That this had too far of implications for emergency departments. How can rural emergency departments or struggling emergency departments accommodate these patients, or why is the law getting involved with what is a patient physician relationship? So they were against it. They were strongly against it. That was really interesting. But it was signed into law in 1986, right, under Ronald Reagan, part of the COBRA Act, right? It was a Budget Reconciliation Act, and it was amended. And here's the thing: people say, "Okay, well, that's it then, right?" No, it was amended again in '88. It was amended again in '89. Final rules, which is kind of what the CMS calls them, final rules, were issued in '94. They were amended to include interpretive guidelines in 2008. And then continuously, there's a state operators manual that for the state people who work in risk and compliance, that's continuously updated with guidance, right? It was updated during COVID when people had a lot of questions related to COVID. So it is not a static piece of law, right? It is quite a dynamic piece. So that was kind of some of the context around that time, but it's not static and it's not finished either.
so you mentioned in your people coming to the ER with gunshot wounds or fetal issues and stuff. But I guess the question is, what this is an EMS topic. So along the lines of what is the emergency department or what is coming to the emergency department, how does that play into what about a patient in an ambulance coming to the emergency department? Where does that fit in?
Yeah, that's a great question, especially relevant for us who are more EMS focused. I'll give you a case, and then we can kind of define a little bit, and it's an example of why that question came up, right? Because that wasn't defined. What is coming to the emergency department, right? And so they had to have a case. This is how the law works, right? It's crazy, finding this out. Like, hey, they had to have a case so they could litigate over it and try to decide. There was a 15-year-old in Chicago. This is where I did my residency and my fellowship. And he was playing basketball outside Ravenswood Medical Center, right? It's a hospital close to the northwest side, I think. He was playing basketball right outside the hospital. He gets shot. He gets dragged by his friends and with the police there within 30 feet of the front of the hospital. people go rushing in, police go rushing into the hospital to the ER. They say, hey, this kid's right outside. He's 15 years old. He's been shot. He's right outside. The ER personnel say, well, no, we're not EMS. We're not first responders. I'm sorry. We can't leave the emergency department to go get your patient. You have to wait for EMS to get there. And EMS brings them in through the ambulance bay, right? They said, look, we can't, we have a policy that says that. We are not first responders. We can't go out into the world and pick up patients. We are here in the ER and we've got patients here to take care of. He unfortunately died from his wounds. And this again was a very public case, right? Made the news significantly, right? He died from his wounds. Now that would be considered an EMTALA violation, because they went forward and they tried to define what the hospital property includes. What does it mean to come to the emergency department? And what does the hospital mean? What is the hospital, right? So they had to define that first and say, what's hospital property? Do you know, Scott, or does anybody know, like, what kind of yards? Have anyone ever heard of a specific number and said, oh,
I've
the
heard
yards?
250 yards.
Yeah,
And most Americans, I don't even know if they know how much a yard is.
I'm
And,
not sure either.
and I
Tell
think
me what.
some hospitals might even do it, saying we don't go past our hospital boundary,
Yeah,
which may be less than 250 yards if someone's on a
maybe
street
not.
and the entrance is close.
So I mean, this is the case where they had to define it. The court had to say something, and then EMTALA had to add a provision. They said it's 250 yards of the main building. That includes your parking lot. That includes your hospital campus. That includes your sidewalks and driveways. What it doesn't include is any doctor's offices, like separate facilities, skilled nursing facilities. If you're attached to like a strip mall and it's a bunch of restaurants, right? They try to say it's the hospital, the parking lot, and the campus of the hospital, right? With the surrounding walkways included, right? They said, okay, that's the hospital. And that if you're within 250 yards of the main building and you're on any of those structures, right, that counts as hospital property. And you, the hospital, need to have a method for getting patients who are looking for emergency care from that hospital property. But I mean, and that's, they had to draw the line somewhere, and someone came up with the term 250 yards, and they said, okay.
So if you're next to the parking lot, 50 yards, you're on the street and you're 50 yards from the parking lot, that's a main street. Is that something that the hospital has to then go into a public location to get a patient?
Yeah, and that's tough. I think if you go by the letter of the law, it says a structure that's even if it's not contiguous with the main building, that counts. But if you're located within 250 yards of the main building, then yeah, you need to have, if someone says, hey, that person's out there and needs help, you need to have a way to get that patient inside, right? At least some method, right? Now, certainly if you say, well, it's not safe for us to go into traffic, well, yeah, that has to be considered too, right? I need traffic control, I need the police, I need EMS, I might need more help than just a stretcher and a nursing team, right, to get that patient, right? And I think the other patients that really get considered here is, what about someone who has a medical emergency in the parking garage and they're on their way to the hospital? What if there's another case of someone who was having an asthma attack and they're at the back entrance of the hospital and they couldn't find the ER? So this is the rule that developed the signage rule, right? That they said, look, all emergency departments need excellent signage for their ERs too, to help patients who are, say you're on the loading gate and you say, I need help and I'm at I need to know where the emergency department is. Now you walk around an ER and you see the signs for the ER everywhere. When you're an ER doc, you're like, oh, why are we advertising the ER to everybody around here, right? But in reality, what you're doing is you're making sure that no matter where you walk into a hospital, whether it's the back entrance, front entrance, loading bay, where it is, and you need emergency care, you can follow the signs and you can get there, right? Something as simple as that. Of course, there were cases in which people didn't make it to the ER in time, which is the sad part. But yes, to answer your question, if it's on the main hospital campus within 250 yards of the main building, right, including sidewalks and driveways that included, I think public roads, that would be a little bit more of a gray area, right, especially with the safety component, right? But it includes the structures and the driveways, though.
So now with the advent of how good we're doing with cars and stuff, what about upwards? So, is 250 yards into the air count? So, I'm
Yeah,
obviously
that's a great
being
question.
quip about it, but what about helipads or air medical?
I'll throw in a couple of caveats. What if you've got a hospital building, but one floor isn't a hospital? One floor is just a residence, a bar, something else, right? Something totally different, something not hospital, right? Does that count? For most hospital systems, you'll have to carve out and in a policy define exactly where those lines are, right? That you'll have to work within the 250-yard rule. mark off those lines. So if you are an ER physician or you're an EMS system, I would just know, if especially if those gray area locations, hey, this is a hospital, but this building over here is actually an inpatient psych unit, right? Does that count as well, right? I would ask that system and their compliance team exactly where that EMTALA components apply to, right? So that you're not having to send your ambulances there when really it might be the hospital that needs to send their nursing team and a stretcher over there to grab that patient, right? So some of you working EMS systems may come across that with hospital partners. But
Yeah.
to answer your question about helipads and air medical, well, let's talk about the ambulances first. If you're just a regular ambulance and you are on the hospital property, right, in that 250 yards, right, that counts as coming to the ED. EMTALA is activated then, right? If you haven't made it to the hospital yet and you're a non-hospital ambulance, right, just like a general municipal fire department, right, that is, the EMTALA is not activated. I'm going to put a little star there because we're going to get back to it later. EMTALA is not activated, but we'll get back to the caveats there. If you're a hospital ambulance, it's a little bit different. You're like a mobile piece of hospital property. So if you're at the gas station, this is our EMS system, we have to work with this too. If you're at the gas station and someone walks up to your ambulance and they say, hey, County General Hospital, that's a hospital, and this got a hospital advertisement on the side of the ambulance. I need emergency care. If you walk up to the ambulance, ask for help, that activates EMTALA, right? You have to have a provision in place for caring for those patients, offering them transport to get an MSC done by a qualified medical provider, like we all do in the ER, right? So even if you're not on the hospital grounds, that counts as well. Now, what about air medical? Scott, you asked about air medical. This is an interesting one. I get this question a lot in a couple different variations of, hey, we've got a helipad, helicopters are landing. Do I need to go out and do an MSC on these patients, right? Before they take off or before a ground unit transfers to an ambulance or vice versa, right? In general, no. For air medical, the helipad doesn't activate EMTALA as long as you're using it for transit purposes, right? So if you were just there as a waypoint between, you know, EMS units, right, and ground unit and air unit, whatever it is, right? If you're just using it as a waypoint, that doesn't activate EMTALA. The exception, of course, is if the individual's condition deteriorates, right? That patient gets way sicker, right? And those providers say they need help and they go to that hospital and they say, hey, my patient's crashing. I need to stabilize them first, right? Any of the medical personnel say, hey, we need help, right? Then that activates EMTALA. In general, though, most of those patients will have had an MSC done prior to, from a sending facility, right? Prior to being transferred. The question comes up is, what if they haven't had an MSC? What if they're going from scene to in a ground unit to a helipad, and then from the helipad to a level 1 trauma center, and they're stopping by this small community emergency department, right? That's a difficult situation. In that case, I would talk to risk and compliance teams. You may need to bless those patients because technically then they've got an EMC, they're on your hospital property, they might need stabilization, they might not, right? Unless someone does an MSC and says they might need help, right? That's a more sticky situation we should talk about if anyone's interested. But in general, no. The sending facility does the MSC. If you're just using it as a waypoint, that EMTALA is not activated.
Good to know, because I think it gets confusing at some points. And like I said to everyone in the group, feel free to put questions in the chat. We'll intersperse them and we'll ask as we go, or we could save some to the end. So as a medical director, where's my liability, especially with medical command calls, or even people that, it depends where you work. So for example, like we talked about earlier in Texas, the ambulance is called the medical director for medical direction. Whereas I'm in the Northeast, that we have base command stations and they call random Dr. X for a command. So where does base command calls and where does medical command in general fall within EMTALA and our liability?
This is an interesting one, and this is where I'll give you a couple cases, and you tell me where you think it's going, right? Because I think the world is still looking. In general, for medical legal liability, you can get sued for anything. Anybody, I think the quote here is anybody with $15 can go to the courthouse and submit a lawsuit, right? You can get sued for anything. For EMTALA, right? If we're looking at liability as from the EMTALA perspective, that's much more specific, right? And I'll give you a case. Here's a case from 1990. It was a 2-month-old. This was in Chicago, right? Mom, 2-month-old having apnea. Baby stopped breathing. Mom called EMS, called Chicago Fire. Paramedics then In this system, they're en route with the baby, or they're about to leave with the baby. They call base station for medical control, similar to a system that you described, Scott. So they call the base station, and there is a nurse telemetry operator on at the time. She told the paramedics that, hey, our hospital, University of Chicago Hospital, is on partial bypass. Go to the nearest hospital, which is not a pediatric center, right? They went to the nearest hospital. Baby was eventually transferred to, a pediatric or PICU capable hospital, where she unfortunately later died. So then there was a claim under EMTALA that because they answered the phone, because they took information about the patient, that EMTALA should work here, right? That the EMTALA says they have an obligation to take that patient and maybe even take them to the pediatric hospital, or to that hospital that's answering the phone call, right? This was in 1991 when this case came forward. They said the court ruling was no. EMTALA isn't activated here because the patient never came to the emergency department. That was the ruling there in 1991. They said, look, you never came to the emergency department. You never on emergency department property. So no, EMTALA doesn't apply here. It only applies to, as we've written, came to the emergency department. That makes sense, right? I mean, I think that, let me know if that seems odd to you, right? But they just looked at the law and they said, well, you have to come to the emergency department for EMTALA to apply. You didn't come to the emergency department, so there's no EMTALA components here, right? There's nothing else. Okay. Now I'm going to give you that asterisk that I told you about before, about hospitals coming to the emergency department. This is a more recent case in Hawaii. And you can see kind of the challenges, is we're still looking to see where the world goes. So this was, the patient's name was Harold Arrington, and the case is called Arrington versus Wong. And they actually list the EMTs that were involved. I don't see this very often. I've looked at a lot of EMTALA cases, looked at a lot of cases related to EMTALA. I've never seen EMTs or EMS providers individually named in a lawsuit or by name, right? But they call it Arrington versus Wong, and then they list the EMT's name. I don't want to say the names, right? But Wong was the emergency physician's name. Right? Harold Arrington, he was a security guard. He showed up to work. He was having trouble breathing. His coworkers said, we're going to call an ambulance. They called EMS. EMS picks him up, right? Is in Hawaii, in Honolulu. They radio ahead to Queens Medical Center, which is the closest hospital emergency department, which is open to EMS traffic. And they talk directly to the emergency department physician there, right? They radioed ahead and they say, hey, this is the patient, he's got trouble breathing. We're doing these interventions. The response back, and then they note that the patient follows with the VA there, the local Army Medical Center, Tripler. And that comes forward in some of the information in the back and forth, that he's a Tripler patient. So the response from the ER physician is, I think it'd be okay to go to Tripler. Tripler was about 10, 15 minutes farther up the road, right? We're talking about like a 10, 15 minute drive, right? He arrived at Tripler at 12:40. He was unfortunately deceased by 1:17, right? Shortly after, he died at Tripler. The allegation was that not only did the hospital violate EMTALA, but so did EMS. What do you think? Why do you think they said that?
Well, so the ambulance isn't part of the system that they're coming from. So I don't feel that it's an EMTALA violation. And now we have the laws where patients are within reason allowed to request where they go.
Yeah,
He didn't
yeah,
request, the physician
absolutely, right.
requested
The
it.
patient preference is a big part, right?
So, and that's before everything was computerized, where, if you want to go to the place that has your records.
Yeah, yeah. And this is
Um,
relatively recently, right? This is in the
yeah. I
yeah,
mean, I don't see how, at least, obviously superficially, this is an EMTALA violation.
yeah.
But you're going to tell me how it is.
Well, I'll tell you what the court said.
Well,
The
that's what I
court
mean.
said,
Yeah.
okay, remember the first case? The first case, they said, you never came to the emergency department. So it's not an EMTALA thing, right? This court said, okay, let us open up. I'm not kidding you here. They open up Webster's Third New Dictionary. They open up the definition of coming to. They literally say coming to is defined as moving towards or away from something. And because you are en route in an ambulance coming to the emergency department, we count that as coming to the emergency department. I kid you not. This is what they did. They pulled up Webster's dictionary. They looked at the definition. They said, oh, yeah, well, this is coming to the emergency department. Forget the 250 yards thing. This is on its way to the emergency department. So this counts.
So
This is
that's
a
every
leap.
patient now.
That's every
If
patient, right?
patients.
This was a leap. And I'll tell you why. Okay, I'll tell you why they said that, right? The reason they said that is, remember my kind of core premise in my one slide. What did I say? I said no dumping, right? And what they were worried about, this was a big leap, and a lot of headlines were made from this in the legal world, right? And the headlines were EMTALA extended to ambulances not owned by hospital. That was the headline in several journals, right? And they made this leap because they said no, because if you start to divert patients before they even get to the emergency department physically, then you're just circumventing EMTALA. You're just finding a workaround, and you're going to start asking patients about their finances, and you're going to start turning them away just to skirt EMTALA. You're just going to say, hey, so do they look poor? Okay, well, go to the county hospital. You're going to start doing that on the phone, and you're going to get away from what the law was trying to do with patients. Isn't that interesting?
So is that the law now?
Well, that's what they were worried about, right? And you say, okay, that was a one-off case, right? And the law is, this is case law. And technically, yes, it was the case law. But what about other cases? Okay, so that was one case, and that I'll tell you where that was. That was in the Ninth Circuit of Appeals, right? So the Ninth Circuit of Appeals is a circuit court, right? The appeals are done, right? That's kind of the last stop, and Supreme Court's not going to hear it, right? And this was in Hawaii, so the Ninth Circuit includes a bunch of states on the West Coast, Alaska, Hawaii, right? All right, what about another case? Remember, they said, look, we worry that patients are you're gonna start dumping patients before they even get to the hospital, and you're gonna circumvent EMTALA. All right, here's another case. A young woman in Puerto Rico. She's got an ectopic pregnancy, and it's being medically managed outpatient. She went to work 2 days later. She's having severe abdominal pain. She called EMS. EMS picks her up. They're on her way to the hospital. The EMS medical director of that hospital, of the ER, right? The ER medical director answers the phone and starts asking a couple questions. He says, okay, ectopic pregnancy. Okay. He asks a couple odd questions. First, he asks, was this a self-induced abortion? Okay. Then he asks, how is the patient going to pay for this? What is their medical coverage? How are they going to pay for this? Right. And then when he got all his answers, he hung up the phone. The EMS crew took that as don't come here. They interpreted that as, well, that means that somehow you're not happy with those answers, and I probably shouldn't go to this hospital then, right? If you're asking me about how this patient's going to pay for it, was it self-induced abortion, et cetera, right? And so here we are. Here's the second case. And the patient was diverted to another ambulance, had a negative outcome, of course, unfortunately, right? And this went to the Federal Court of Appeals, where Puerto Rico is, which is the first Court of Appeals, which is Maine, Rhode Island, Massachusetts, New Hampshire. They said, look, this is exactly what the Ninth Circuit was worried about. This is exactly what we said we were worried you guys are going to do. You're going to screen patients before they ever get to the hospital, and now you're violating the spirit of EMTALA. That this is an EMTALA violation. Yeah, you never came physically onto the emergency department property, the 250-yard rule, all that, right? But you're screening patients for money before they even get to the hospital, and you're dumping them somewhere else. That's what they claim. And that's binding case law now for First Circuit and Ninth Circuit, right? So that's two circuits. There's only 10 of them, right? That's two circuits of Court of Appeals that have said the same thing, worried about the same thing, and said, look, EMTALA now applies to non-hospital ambulances. I don't know if that surprises you or surprised anyone else on this call. I was very surprised to learn this, to read about this, to read the law articles about this, right? But I'm interested what you guys think. If you guys are like, yeah, that makes sense. For me, that's like, wow,
Well, I mean,
that's
that
new.
is pretty, yeah, that's news to me. And along those lines, Dr. Rasnick has a question from San Antonio.
Oh,
Um, so an ambulance is en route to the ED, and the radio room nurse, which I guess you have those in Texas, says, don't come. So the ambulance gets scared and doesn't come. Um, is that an EMTALA violation against the hospital? And it sounds like from what you've been talking about, it's along those lines.
I mean, the question, I guess the answer would be maybe, right? Why did they say don't come to that hospital? Is it something is it a standard that you'll apply to everybody who's trying to come to that hospital, like a diversion status, to say, hey, we're on a total disaster, or we don't have the capabilities, or we are so full in capacity, and there's another hospital that does have capacity that's in reasonable distance, right? That's where applying, and you can see the spirit, right? The spirit is no dumping. Don't screen these patients for payment. Don't turn these ambulances away, right? But if your intentions are good, let's say it that way, right? That you want to help patients and you're open, but today you're closed to stroke because your CT scanner's down or something, right? Is it something you can apply to multiple types of patients coming in, and is it in a policy somewhere that you can apply equitably, then it wouldn't be, I don't think it would be considered an EMTALA violation. But if you start to say, no, we're full, but only to you because it sounds like you've got a homeless guy or he's been here before and I don't like this patient, right? That's a problem. That becomes an EMTALA issue then, right? That you are screening patients that you wouldn't apply other criteria to or written criteria to. So I think it comes back to what is your community standard and are you following it, right? What is
So it
written
sounds
out on
like, yeah,
policy?
sounds like if you're doing it for a group of people,
Yeah,
i.e. stroke patients, it's less of
yeah,
a concern than because you're
right.
not.
If you have
So,
a valid reason, right? A valid policy-driven reason.
and the second question about Dr. Resin, which honestly, within the last month or two, I got a call from my local department uh, that does EMS, and they said, "Hey, we're holding the wall here for an hour.
Oh, yeah,
Um, we want to leave and go to another hospital.
yeah.
Um, is that an EMTALA violation against the hospital?
Mm,
Because they're on hospital property, regardless of the stretcher. It doesn't matter whose stretcher they're on. That I know.
yeah, yeah,
Um, but they want to leave and take this person to another hospital.
yeah.
So where does that fit in with EMTALA?
I think, well, and then there's a lot of layers there, right? In general, that patient needs an MSC, right? Like I mentioned in some of those core provisions of EMTALA, right? They have to get a medical screening exam, and if they find a medical screening exam, they have to get them stabilized, or if they can't stabilize it, they have to effectuate a proper transfer between facilities, right? They can't just say, okay, get out of here, right? So it may be depending on what that hospital is doing. Now, let's say a hospital has a physician in triage, they evaluate you, they put an MSC note, right? And that's been documented already, right? That the patient needs XYZ to get their MSC done, which is another separate conversation, right? MSC is a continuous process, it's not a one and done. It's not, I look at the patient, MSC is done. It's usually something along the lines of, well, I need a CT and maybe a lumbar puncture and maybe some labs to help figure out if there's an emergency today, right? That's most of our patients. Um, that is a challenge because then, yeah, there may be an EMTALA issue there against that hospital. Ultimately, though, and we can get to some interesting EMS cases, but most of the time that's up to the hospital. And when you show up on their property, they have to effectuate getting an MSC done and taking care of that patient per federal law. I think another common variation of that question I get is, what if my medics leave? Like they just leave the patient there at triage. Is that an EMTALA violation? Not necessarily, no. Not for the EMS agency, right? If that hospital doesn't evaluate that patient, treat their medical condition in a timely manner, that's an EMTALA issue for that hospital. But for the EMS agency, no, as long as they can, and this is where I encourage you to work with your hospital partners, right? Work out a system, have a collaborative relationship, right? And be able to care for that patient in a holistic manner that gets them the timely care, but also addresses the wall times issue, right? That'd be beneficial for everybody. But shouldn't be an
So,
EMTALA issue for EMS.
right, but if EMS says, I want to do the best thing for this patient and take him down the street where I know there's no wait time, but
Yeah,
they don't get a medical screening exam,
yeah,
then the hospital seems like they could be held liable, even though
yeah.
they were not the ones that told them to leave.
Correct. I think the challenge here, especially for the EMS team, is um, being a part of a case that may be investigated for EMTALA. That's something you probably don't want as the medical director, right? And that's the hard part is you want to support your teams, you want to support the patients, right? It's one thing if it's patient choice, but if your crews are saying, okay, hospital A is too full and I'm going to drive away and I'm going to go to hospital B now, even though I was on property of hospital A, well, guess what? When they investigate that case, and who investigates these is the Office of Inspector General under Department of Health and Human Services, right? When they investigate that, guess what? You're gonna have to buy the Costco pack of Tums for your medical director because it is going to be a huge nightmare. It's going to take many years, right? And let me give you an example too. Let me give you an example case. All right, so there's this recent 2019 MVC, motor vehicle collisions, multiple injured, lots of cars involved, right? EMS takes them, they're en route the patient. They contact a local Georgia hospital and they say, look, you're the closest. We've got some really sick patients here. On the phone, they recommend, and this is the right thing. Hey, some of these patients are really sick. You should be going to the trauma center, right? The level 1 trauma center that can handle these down the street. Don't bring them here. Okay. They say, okay, well, we'll try, right? Patients are getting sicker while they're trying to get en route to that trauma center. And they say, no, let's just pull into Georgia Hospital. They pull in the ambulance bay. The nurse comes out and says, no, no, no. I talked to you guys on the phone. This guy's way too sick for us. He needs a trauma center. You guys should go to the trauma center. Ambulance leaves, the patient deteriorates, ultimately dies before they get to the receiving hospital or as soon as they get there. What's the problem here, right? What did they not get at the Georgia hospital? The MSC, right? They didn't get their medical screenings and they didn't get stabilized, right? There was a chance that we could have saved that patient, stabilized them, right, before they went to that other hospital. And they hopefully could have prevented that outcome, right? Even though they're not a trauma center, right? There's an emergency department. They're calling themselves an emergency department. That's an emergency, a patient with an EMC. So is the EMS crew particularly liable here from the EMTALA perspective? No, and I don't think they found EMS liable in this case. Guess what? They were intimately involved with the case every step of the way of this whole investigation, right? And that's where your medical director and your EMS leadership and your even the EMS teams, right? We don't want to be involved with that, right? That's like a career-ending investigation. You'd be like, look, I'm sick of it, right? We're talking about burnout EMS, right? This is a fast track to burnout for a lot of people, right? For those providers, for that medical director, and all those people. It's not worth the headache, right? So that's where I caution you, and to the question from San Antonio, right? If you can avoid becoming a subject of investigation in any way, shape, or form, right? And before that happens, that would be much preferred.
So there's two people had Dr. Stone had a statement he wanted to make. Dr. Stone.
So good evening to all. Hashim, great presentation. Thanks so much for your efforts in getting it together. As you were presenting the perspectives and the case law over time, I couldn't help but want to bring to the group what I think is a very healthy way of the synopsis that goes with EMTALA as taught by one of my greatest mentors. He actually became a mentor when I already had a gray beard. Is Dr. Larry Weiss. At the outset of the discussion, you said, Hashim, I'm not a lawyer. Don't play one on TV, and most of us aren't. But Larry happens to be both. He was a big litigator and a career mercy physician at LSU, and we were blessed to have him come to Baltimore on the heels of Hurricane Katrina and spend the better part of a decade on the faculty before retiring. And I think he was one of the inaugural masters of AAEM, sort of created that level. And I know that if Tom Doreen is listening, he knows how fond I was of Larry's teachings. He put together for our faculty a talk called EMS and the Law with a spin about Maryland as well. But one of the things I think is very important to take away from any discussion on EMTALA that I wanted to share as a synopsis is his teaching that EMTALA is not a med-mal statute. It's an anti-discrimination statute. That's the term he used that I think that I wanted to share with you all. And the absolutes that sometimes came with case law can sometimes be warded off when you think of and you started to refer to this in the latter parts of your talk about treating all people the same. So for instance, the 250-yard rule, there are certain safe havens that clearly are not against the spirit of EMTALA. And what has been mentioned in some of the case law is the idea of decision making that is part of an established local EMS system. When you are following the decision making process, that you may not be held to the strict thing like if you're en route to that place, automatically the patient wanted to come there. So a common example is a construction worker who's in the parking garage at MedStar Montgomery Medical Center, which is a great community but not trauma center, right? Falls off and has category 1 type injuries by the CDC triage guidelines. He's 200 and not even 200 yards from the front of the hospital. We get on the scene. We're extricating him from the gully or what would we do with every single similarly situated patient in that case? Is we give them the care that they deserve. So if you drive off the hospital property 200 feet from the front of the hospital to go to the trauma center with that patient, it's not an EMTALA violation from the Montgomery General as what people might think just because of the distance. Because what you're doing for that patient is you're not treating him with discrimination. It's not a med-mal statute. Another thing I understand from Larry is he said that when slick lawyers tried to sue under EMTALA because you get triple damages when you're successful, Courts saw through the ruse of people trying to use or extricate from the EMTALA statutes what really is a negligence claim, a simple med malpractice.
Yeah.
And they've had cases thrown out with really bad outcomes that had nothing to do with EMTALA and had everything to do with an allegation of negligence. They never ruled on the merits because it wasn't a violation of EMTALA. Similarly, if you had a patient by the grace of God, and they actually weren't too injured and they went on to be okay, but it was an egregious violation of EMTALA. There were cases in law where the person was fined, that they had the bejesus fined out of their their personal assets because it was clearly a bad decision based on the EMTALA statutes, even though the patient was not necessarily harmed as an outcome. So I think it's important to differentiate, to make that statement about EMTALA and realize that at the end of the day, if we're making solid patient decisions that are not in violation of the spirit, I don't think that those folks are on iffy ground simply because it was a hospital ambulance. If they're doing the right thing by EMS statute, by EMS protocol, and applied in a non-discriminatory fashion, I think you're safer. And by the way, one more safe haven. If a helicopter is landing in the helipad 2 feet from the front of the hospital because the accident was down the street, and it's unsafe to land the helicopter in the middle of the roadway or in the trees, and the ambulance comes onto your property, when that person pops out of the ambulance to go into the helicopter, the ED doc doesn't have to come out of the ED and just like Ravenswood, even though the distance was exactly like Chicago Ravenswood, the ED doc doesn't have to come out and stabilize that patient because that patient is being treated the same way. Now, if the person goes in and says, I got an unstable airway, can you help? That's different because the EMS provider is making a decision that for all intents and purposes, the stabilization of the airway, we need to take that person in there rather than have them die in the helicopter. Different situation. But those are the things that I think really guide us. And why Larry talked about that is the idea that we're doing the right thing. We're not dumping, and we're treating the patients medically the same way we would treat anybody in a similarly situated medical presentation. So with that, I thank you guys for listening.
Yeah, no, thank you. That was really informative.
Agree with everything said there. And as you mentioned, it's about the equity, right? Applying the same community standard that you would to everybody in that situation, right? And that core of EMTALA, no dumping. You can't pick out the patients you want and you don't want and apply the rules differently to them, right? And the more you have in policy and the more you have in writing on what you do with those situations, those carve outs, right? What do I do when a helicopter's here or there, right? That's protective. That is risk mitigation, right? Because then you can apply those rules, right? Equitably and transparently, right, to everybody in the community of here's how we do it, right? And another thing I'll add is you mentioned some of the penalties and fines. So if you get investigated for EMTALA, or a lot of these emergency departments, it's not a single case. A single case may trigger investigation, but they're going to pull records for many, many, many cases. So you'll see this on the website for OIG, right? The Office of Inspector General has all the claims and EMTALA, settlements, and they look back and they say, well, this was what the index case was, but then we found 5 other cases in the last 10 years, and we're finding them for all of them too, right? They're looking for those times where you selected out your patients, where you performed what they would consider patient dumping or violating the spirit of EMTALA, right? And that's important that you adhere to those written rules and regulations that you set out and you say, this is what's fair, and this is what we're doing.
Dr. Cooley, did you have I saw your hand up and it went back down. I didn't know if it was answered already. I didn't know if you had a statement.
I was going to just make a quick comment, and I tried to put it in the chat. I don't think it got in there, about the situation where the patient or the crew wants to leave the hospital to go to a different hospital. That wasn't necessarily as hypothetical as it might have seemed, but it's when that does tend to happen, it's amazing how fast that MSE occurs as you're trying to leave the building. So, and again, it brings back the issue that the onus of EMTALA is on the receiving hospital, not EMS, unless of course they're hospital based or or they do something egregious, because it's they're once they cross that magic line, however they do it, it's the hospital's issue, not EMS. So EMS doesn't have that violation.
And I think most hospitals know this. And I think as soon as you raise this issue to a CMO or administrator and say, hey, we're going to consider leaving the hospital after this, or putting you guys at risk, right? The response is very prompt and very different then, right?
And I would say to the point where sometimes it's even potentially detrimental to themselves. There was a particular case where the crews were told they want to take the patient, it was a pediatric patient, to X hospital over and over and over, and everything, they show up at the back door, they were like, no, we want to go to the other hospital down the street. And so the crew called me, and I was like, okay, well, if everybody's on board with that, that's fine. It's not EMTALA. We're the ones leaving. But of course, the hospital freaked out.
Said, no, but exactly.
Kind of couldn't want to leave. So whatever.
And if there's a happy ending there, right, I think that saves the crew, especially if there's a negative outcome, right, as we talked about for that Georgia case, right, or the trauma patient that died. And if it saves the crew and it helps the patient, right, then that's a great middle ground for everyone. Then if we can move those things along.
So, as these things are, and this next question is really, I guess I'm being selfish, because in the Northeast, we're having a lot of stuff happening next year. We're having FIFA coming to Philly, 250th anniversary of Army, Navy stuff, a lot of stuff happening in the Philly area. What about disasters and mass casualty instances? Does EMTALA still apply to that?
Yeah, and I think a common pitfall, a common misconception is that EMTALA gets waived in disasters somehow. Yeah, I'll give you the brief summary. The spoiler alert is no, it is not waived. Asper Tracy has a great document from HHS as well, a collaborative document on EMTALA and disasters published in 2018 that's still relevant today. The bar is exceptionally high for EMTALA to be waived in a disaster, and to do it even retroactively is even harder. So no matter what the disaster that we've seen so far, whether it's COVID pandemic or whether it's a 10-car pileup, right, that does not waive the EMTALA obligations. In fact, I think they even worry the opposite, that because there's a disaster, they worry that you all will forget the EMTALA, implications and the need to treat all those patients the same way you would, and not select out the patients who are this sick or that sick or this poor or that rich, right? So I think in general, HHS says no, it is not waived. There's a rare chance it could be waived retroactively, but we will tell you when it's waived. And it wasn't waived in COVID, and it's not waived, and it has not been waived, as far as I know, in any recent history. They recommend, of course, if you're a hospital, that you shore up your disaster and surge plans, right, to be able to comply with EMTALA. That's what they recommend.
Thank you very much. I mean, this has really been informative, because, a lot of us are EMS and kind of, law or EMTALA, which is along the law side, is not always crystal clear. Obviously, it's quite muddy. So I really want to thank you for this and sharing your expertise and reflecting on this. I do want to take the last 2, 3, 4 minutes. Do you have any take-home points for people?
Yeah, I think, talking about some of these cases and talking about kind of the spirit of EMTALA, I think now that you guys have some framework, some mental model, right? Remembering that I think for everyone, assess where the EMTALA risk is in your agency, right? Is that crews trying to drop off at the emergency department? Is that trying to transfer patients across the state? Is that trying to meet up with a helicopter, right, and intercept patients, right? Where is your EMTALA risks? Where will patients where EMTALA applies deteriorate? And what does it look like, right, if that standard is not applied appropriately, especially in the setting of that new coming to the emergency department, where EMS may very well be included and has been included in those 2 cases. I would say take home is educate your crews on it, right? Look up some of these core components. I'm happy to share any slides, right, that I have too. Educate your crews on it. I think it's important that the EMS crews are also aware, right? So when someone runs out into the ambulance bay and says, no, go to a different hospital, right? They know that they can't do that until there's an MSC, right? It's not their role, but as part of the team, and especially an important part of the care team, they have to recognize what that hospital's obligations are as well. They can prevent risk for you and your agency by doing so. And then I would say collaborate with your hospitals, right? Develop those, try to get a seat at the table so that when you can, we can avoid those situations where there might be perceived patient dumping or EMTALA issues, right? And that happens by collaborating and having a seat at the table and reminding hospitals and your partners in the region of what are obligations as both EMS providers and emergency providers under EMTALA.
Thank you. Any other statements, questions, concerns? I don't know if you know this, but you have the distinct honor of, this is the last webinar for this year's series. So thank you so much for everyone attending the session. And for, tonight's webinar concludes the 2024 to 25 Futures of EMS webinar series. We'll have future announcements for the next set of series, which will be done by the next EMS counselor, which probably might still be me, which is fine. So check the webpage out. I put it in the chat for you guys to access if you need to. And thanks again for everyone for joining. And we look forward to seeing you guys soon. Yes.
Hey, Scott, real quick. I was wondering, I apologize because I may have had to let a barking dog out a little bit. So did anyone ever address what Dr. Stair had asked about his experience with a long haul transfer to a special care center, winding up at the wrong hospital and realizing it once they got in the parking lot, what happened to Luke? Did we talk about that? Because I think that speaks to what we were talking about. What constitutes wanting to go to that ER? Is that something you guys had caught in the chat box?
No, but I could bring it up real quick. So, someone brought up that they were going on a long haul transfer and they went to the hospital, but it turned out it wasn't the right hospital and they wanted to go to the hospital they were supposed to go at, but they weren't actually, quote, allowed to leave until they got their MSC.
Yeah, and I guess in this case, it's an inter-facility transfer, or is this a 911 patient going to a?
It looked like a 911 service.
Yeah,
I think
in those
it
cases,
was 911 service, but sometimes we would do long haul transfers, and so that's what this was. It was a non-emergent to a higher level of care, and we went into the ambulance bay, realized it was the wrong one, but then even though the patient we never unloaded the patient from the ambulance.
Yeah.
And never left the ambulance bay, we were not allowed to leave until an ER physician came out and into the ambulance and did an assessment on the patient.
So the reason I brought it up is there is where I'd argue a couple things in the spirit. The definition of the patient coming to that ER, that patient signed, if the patient was alert, signed a declaratory intent that they were being transferred to a higher level care, and that they were not specifically not going to that ER.
hospital.
So you could make an argument that if you drove off the property under those circumstances, anyone else treated the same would have said, oops, we just went to the wrong hospital because of and it would be a safer haven for you to leave and to go to the right hospital because they're the patient intended on going to the other hospital.
And you were at the
it's
lower
probably
level,
better for the hospital that they go to that other hospital because the other hospital that sent them already couldn't take care of them.
Yeah.
So this is one where if we hold to this 250 yards or we hold to the you intended to go under all circumstances, it may not be a very patient-centered requirement that, oh, you couldn't leave. And I would happy to be an expert. Well, I don't think I would be considered one, but if someone tapped me, I'd be happy to testify. What else should that ambulance have done? So I mean, that's why your question was one that caught my eye as an example of this anti-discrimination argument about what the law is really there to do. I think your patient probably would have wanted not to go to that ED. And
I agree. And in some cases, it may be beneficial for them not to be in that ED, right? There may be specific benefits for them to not be there. I think the challenge will be you have to talk with the hospital and your EMS compliance teams, right? Of what they would want done in that situation. I can see many hospital compliance folks saying, well, you're on our hospital property, right? This patient needs some kind of acute care. Maybe it's emergency care. Maybe it's something more, right? You're trying to get to hospital B, but you're on our hospital, right? They should get an MSC to be equitable. Equitable in the sense that many hospitals may have to perform emergency care for patients that were intended to go from hospital A to B, but hospital C, they have to divert, for example, to get an airway or to stabilize their blood pressure, right? So I think that's where I would collaborate with your hospital partners, right? And be clear about what the request is and what the patient issues are, right? Because maybe you can get a carve out on paper, like I said, right, where it is applied equitably. They said, okay, if this is a mix-up and you were trying to go from A to B, then we've got it on paper. It's documented as a policy somewhere, right? That this does not activate EMTALA in our eyes, right? And it's not going to be patient dumping. But I would keep that in mind that there may be cases in which they say, look, we want to do an MSC because we want to make sure that patient's okay, right? We don't want the liability that they're on our property and then maybe they die in the second leg of their transfer there. So I think that's where the collaboration becomes really key. To work through these situations and put them to paper rather than do them fly by wire or ad hoc, right?
Okay. Well, once again, I want to reiterate and thank everyone for coming. And Dr. Zaidi, thank you again. That was really informative.
No problem. Thank you for having me.
Of course. And I look forward to everyone next year's season. Thank you, everyone, and stay safe.
Thank you.
Scott, great.